Hello everyone and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I am Dr. Ashutosh Lal and I serve as Professor of Clinical Pediatrics at the University of California, San Francisco School of Medicine. I also direct the Comprehensive Thalassemia Program at UCSF Benioff Children's Hospital, Oakland. I'm pleased to be joined today by Dr. Elliot Wichinsky, MD, who is Professor of Pediatrics at UCSF School of Medicine and directs the Northern California Comprehensive Thalassemia and Sickle Cell Disease Centers. Dr. Wichinsky also serves as Medical Director of Hematology Oncology at UCSF Benioff Children's Hospital, Oakland. We are both delighted to be with you today to present a 2019 scientific update on transfusion guidelines for thalassemia. Before we begin, I'd like to go over a few points and helpful tips for joining this webinar. Upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with a phone and access number and audio pin. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of your toolbar. Keep in mind that you can submit questions at any time. They will be saved for the Q&A section at the end of the presentation. We will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. Let's begin. We will begin today's webinar first with two brief audience polls. First, we are interested in knowing more about you. When the first poll question appears on the screen, please select your response. You can answer the question directly on your computer screen. Please go ahead and respond now to the poll question on your screen. Can we see the results? So the poll shows that the audience today, 62% are healthcare providers, 11% are public health professionals, 16% are persons with thalassemia or a family member, 3% are community-based organizations, and 8% are industry partners. We now move on to the second poll question. Please respond on your screen. So this shows that 86% of the audience today is from North America, 2% from South America, 1% from Europe, 10% from Asia, and 2% are from Africa, Australia, and New Zealand. Thank you for your responses. Now let's begin our presentation. Dr. Wichinsky will first provide some background on complications of transfusion therapy in thalassemia. Dr. Wichinsky.
Well, I'm delighted to go over this topic for you. I think it's an extremely important one, and the standards have been changing over time as we better understand the safety and risk of blood transfusions. So my goal here is to share with you our view of standards of care and transfusion complications. The first slide illustrates our overall goals with transfusion therapy. The appropriate goal of transfusion therapy is optimal safety of transfused blood, and the key concepts in this protocol for routine administration of red blood cells to patients with thalassemia. What this specifically refers to is 1, the use of donor erythrocytes with optimal recovery and half-life in the recipient. Number 2, the achievement of an appropriate hemoglobin level that you have decided on. And most importantly, the avoidance of adverse reactions, including transfusion-related complications such as infectious agents, as well as hemolytic and allergic reactions. There's a large number of potential reactions that can occur with transfusion. And one of the most important things to keep in mind that since these patients are transfused over many, many years, the chances of getting these increase as longer they live. So with one transfusion, the risk may be low, but over time they accumulate and the total number of reactions are surprisingly high. Many patients can have non-hemolytic febrile transfusion reactions. There's a high rate of allergic reactions that can vary from itching to anaphylaxis. One of the most serious is an acute hemolytic transfusion reaction. At the time of the transfusion, they can have a sudden reaction with fever, chills, and remarkable fall in the hemoglobin. One of the more common transfusion reactions is the delayed hemolytic transfusion reaction. That is, they go home and then develop the hemolytic transfusion reaction. One of the problems for the doctor, the patient, and the blood bank is alloimmunization. This interferes with matching the survival of the transfusion and is a long-term serious problem. This is often accompanied in patients who are alloimmunized by the development of autoimmune hemolytic anemia or auto-alloimmunization. As patients age and they're exposed to products, they're at risk for transfusion-related acute lung injury or TRALI, but also transfusion-related fluid overload, and most importantly, transfusion-related infections. Iron overload is a serious core problem from transfusions, and that was explained in the last presentation by my colleagues, in which I will briefly touch on. Alloimmunization occurs when antigens from the donor blood do not match the recipient and the patient develops antibodies against the donor blood. Now, since most patients are only transfused rarely who don't have a chronic transfusion disorder, such as for surgery, blood banks screen only for ABO-RH antigens. But in the chronically transfused population, it is necessary to screen and match donor blood for a much larger panel of antigens. Big Kel, Big E, Big C, and JKB are extremely immunogenic, and they cause severe hemolytic transfusion reactions. Preventing these reactions by prophylactic matching these patients with the donor can prevent these problems. We're learning a great deal more now, and red cell phenotypes have historically been always serologically determined. But with the development of genotype testing, we've been able to uncover that 20% of the patients who had appropriate phenotypic matching may have mismatched antigens not seen in the phenotype that could lead to reactions. Autoimmunization is when the patient develops antibodies that attack their own red cells. Most of these cases are preceded by patients who have been documented to have alloimmunization. This is a serious problem, whether it causes autoimmune hemolytic anemia or not, because the autoantibody will interfere with cross-matching. Many of these don't have antigen specificity, and it's difficult to find the best units. And at times, they can cause life-threatening hemolytic transfusion reactions. In a national collaborative study of thalassemia sponsored by the CDC, in which the authors and I self-published in 2014 in Transfusion, we followed the history of 407 patients prior to enrollment through detailed chart reviews, and then during the time on the study. And I just wanted to give you some interesting highlights. The average age was 22 years of age, but it varied. There was a bimodal population of majority being young and some older patients. Surprisingly, 25% of the population were transfused outside the United States. This reflects this population being largely an immigrant population, and they moved to the United States with a history of thalassemia or a history of transfusion. This is very important for the physician to determine when they first see a patient. Of importance, 24% of this population who was often transfused outside had a history of a probable transfusion-associated infection. These included hepatitis A, B, and C, malaria, parvovirus, and a recent rise in babiosis and a steady depending on the region, HIV. During the trial and during the monitoring, there was a remarkable number of a diverse type of transfusion reactions. Overall, 52% of the entire population had documentation of a reaction, usually allergic or febrile, but sometimes hemolytic and sometimes life-threatening. When one looked at the antibodies, 19% of the whole population were immunized, usually to E, C, and K, often multiple antibodies, and of those total population, 7% developed an autoantibody, and most of those were alloimmunized. When you look at more detail in this population, you would see that 47% of the transfused population had multiple alloantibodies, and that of this group, 70% of the antibodies detected with big E, K, and C. Now, there are risk factors that complicate the transfusions and increase transfusion-related events in thalassemia, and I highlighted some selected risk factors. One is splenectomy. The utilization of splenectomy has gone from 3/4 of patients being splenectomized to a cautious concern to only use it in the most selected cases. That is because splenectomy removes the immunologic protective function for the patient. It remarkably increases the sensitization to antigens, and overall results in at least a 2-fold increase in alloimmunization following the splenectomy. In addition, splenectomy results in an increased rate of thrombosis caused by release of circulating procoagulants, platelets, and other factors that cause thrombosis. In the population as a whole, 7% of the patients developed significant thrombosis, all were splenectomized. Another risk factor is matching of the units. Overall, there were 20% of patients generally get alloimmunized, but in a subgroup studied who received adequate phenotyping before the development of the antibodies, only 9% got antibodies, in contrast to 24% who never got phenotyped. An interesting factor is the age of initiation of transfusion that supports the observation that infants under a year of age develop an immunologic tolerance to foreign antigens. And in the transfusion study from the CDC, we found, though they received the most number of units, children under 1 year of age only had 11% rate of alloimmunization, and those over a year of age had a 30%, indicating an interesting observation that very young children may develop tolerance. Clearly, the risk of alloimmunization and transfusion complications correlate with the number of units exposed, and the rates are higher over time in those on chronic transfusion. Delayed hemolytic transfusion reactions is one type of reaction that all providers of patients being transfused should be aware of. This generally occurs after the child or adult goes home 3 to 10 days after the transfusion. They appeared to have a serologically completely compatible unit right before the transfusion, and these patients, turns out, were alloimmunized to red cell antigens in the past, but that alloantibody became non-detectable. This is common with KID, Duffy, KEL, and MS system. So you can't rely on the cross-matching at the time of transfusion to detect low titer antibodies. Antibodies at very low titer are not detected during the cross-match and then are re-exposed. If they're exposed to that antigen, it triggers an amnestic response with a rapid rise in that specific antibody and the induction of a hemolytic reaction many days later. These are often extravascular. The patient starts to develop a fever, their eyes got yellowed, they get fatigued, and if tested, they'll be anemic, and at that time, the antibody will be positive. This can be prevented. Probably the most important thing one can do to prevent reactions is to sustain very good blood banking records to know about these transient antibodies. Transfusion-transmitted infections is an ongoing changing problem for the transfused patients. And the organisms they are getting are changing, and the CDC is developing new technology to try to detect the newer contemporary infections. Historically, and in countries that don't have access to adequate testing, hepatitis B, hepatitis C, HIV were very serious problems. Recently, babiosis, plasmodium, Dengue, and Zika viruses are on the upswing. The CDC is engaged in an ongoing surveillance program that tests all blood products to determine viral exposure and risk at this point. And the thalassemia population, because of their exposure rate, is a critical group to monitor over their lifetime to determine what infections they're risk for. Here you can see some of the CDC results using very specific nucleic acid testing or molecular testing and what the rate of infection is in patients who have during that safety window. You could see that with HIV, despite the techniques being used now, 1 per 2 million, for HCV, 1 to 2 million, with a window of 7 days, for HBV, 1 per 1.7 million, for HTLV, with a window extending out 80 days, about 1 per million. And recently, the studies with West Nile virus and Zika show that these two can be transmitted despite the existing techniques used. What can we do to prevent this? Well, first of all, is really complete and adequate immunizations are needed to hepatitis and other infections. Pre-storage leukodepletion is an effective method to remove many of the infections, because many of the infections, CMV, EBV, and others, are predominantly transmitted only in the white cell. Another important infection that I didn't have time to cover is the iatrogenic bacterial contamination of the unit or of the transfusion process. This can often lead to death. So it's very important to have early diagnosis and treatment of suspected bacterial contamination. In general, the units that are younger are safer to use in terms of infection rate, and hopefully in the near future, nucleic acid pathogen reduction systems will become universal. These techniques, such as illustrated in this slide, really inactivate all infections within a unit by really going after the active nucleic acid, and are very effective in really sterilizing the units. What is important and what is being studied now is, do these affect the post-transfusion viability of the units? While worked out quite well with platelets, the work now is being done in red cells, and it's most likely that these type units will be available for red cell transfusions in the near future. Iron overload is a core problem in transfusions. And a prior talk of the CDC covered this in detail. So I'm just going to highlight some of the key points for you to remember. The transfusion volume is related to the iron loading rate. Each unit of blood contains 200 milligrams of iron. An iron loading rate can be calculated a milligram of iron per kilogram per day. On the average, patients have an iron loading rate of 0.3 to 0.5 milligrams per kilogram per day. When iron intake is high, there needs to be an adjustment in the chelation dose. Maintaining transfusion records and tracking the total volume of blood wherever they are is really a simple but critical step to monitor blood use and complications. Next, Dr. Lau will now present the transfusion guidelines for beta thalassemia major.
Thank you, Dr. Lachinsky. So the next several slides, I will highlight some of the current thinking and recommendations of transfusion therapy in thalassemia major. Some of the topics that I'm going to be covering are why transfusions are needed, should all forms of thalassemia be transfused identically, what are the sources of the existing transfusion recommendations, what are the indications to start chronic transfusions, what hemoglobin targets to maintain, what should be the specifications of the RBC product, what is the antigen matching recommendations, and then I'll have a summary slide at the end of it. So let's begin by asking why transfusions are done in thalassemia. And the first reason is anemia. Now, chronic anemia has serious consequences. For example, in children, reduced physical activity and growth, liver and spleen enlargement, weak bones, delayed puberty, effect on cognitive function, and increase in basal metabolism, which has nutritional consequences. In adults, there's reduced capacity for work, effect on cognitive function, fatigue, osteopenia, and a poor quality of life. It is evident that higher hemoglobin will alleviate fatigue and improve work capacity. There are general guidelines that have been published by many different societies, including the AABB, the Blood Bank Society, which presents a transfusion threshold of 7 to 8 grams in hospitalized patients, but this does not apply to transfusion-dependent anemia such as thalassemia, because unlike chemotherapy-induced or post-operative anemia, individuals with thalassemia have a lifelong anemia and expect to be fully functional at work and in personal life. And secondly, the benchmark for alleviation of symptoms of anemia and thalassemia is really comparison with normal individuals. The second aspect of transfusions in thalassemia is the role played by ineffective erythropoiesis. Now, this is the central and distinguishing feature of thalassemia, which separates it from the other hemolytic and hyperplastic anemias. The hemolysis, in fact, is a relatively minor contributor of anemia in thalassemia. There is a globin chain imbalance that in beta thalassemias leads to alpha globin aggregates in the erythroid progenitors, so that most of the progenitors will die before they mature into reticulocytes. And this leads to an EPO-driven expansion, a massive expansion of the bone marrow that can produce changes in the facial skeletal vertebrae in weak bones, enlargement of the liver and spleen causing hypersplenism, and then it also suppresses the synthesis of hepcidin, and that in turn increases iron absorption from diet. The hemoglobin level that's needed to suppress ineffective erythropoiesis may in fact sometimes be higher than that needed to just merely alleviate the symptoms of anemia. And these factors have been studied extensively by Cazzola and colleagues in the 1990s, and the figure on the right shows the effect of the pre-transfusion hemoglobin. Down here, with the soluble transferrin receptor, which measures erythropoietic activity, and on the right, it tells us how many times normal marrow activity there is. And as the pre-transfusion hemoglobin level increases, there's a decrease in erythropoietic activity. Now, we think that when you reach a pre-transfusion hemoglobin of 10, all patients will have erythropoietic activity below 10, Whereas if your pre-transfusion hemoglobins are between 9 to 10, then many patients will have increased erythropoietic activity, which could be anywhere up to 4 times normal. But if you're below 9, then really your marrow activity is enormous with those numbers. So these investigations have been very informative in forming the opinion on what kind of pre-transfusion hemoglobins to maintain. The third issue in thalassemia is the type of hemoglobin which directly relates to the oxygen transport. So when all the hemoglobin inside the red cell is the fetal hemoglobin, the oxygen delivery is less efficient because fetal hemoglobin has a much higher oxygen affinity compared to adult hemoglobin. And in beta thalassemia major, hemoglobin A is either severely reduced or it's completely absent, and it is replaced by F to a variable degree. But in other forms of thalassemia, such as the E beta thalassemia, the A hemoglobin or the adult hemoglobin is replaced by E and F, and E in this case has a normal oxygen affinity similar to the normal hemoglobin A. So these factors are important in determining the person's ability to cope with a level of anemia, and the individuals with thalassemia who have identical hemoglobin levels may in fact have different tolerance to anemia and bone marrow activity, which means that often we have to individualize the pre-transfusion hemoglobins to different patients. What are the reasons for a common issue that we've seen, which is underutilization of blood transfusions in thalassemia? Well, first of all, there may be an adoption of treatment standards developed for other conditions, especially if a practice does not follow a large number of patients with thalassemia. Second is sometimes providers may not expect the patients or the persons with thalassemia to achieve normal physical and professional accomplishments as the normal population does. There is also legitimate concern about iron loading, as well as concern about the donor exposure. And finally, there's concern about blood safety and concern about blood availability in many parts of the world as well. So the question that we pose is, should various thalassemia syndromes have similar approach to transfusion therapy? So there are 4 common thalassemia syndromes out there: beta thalassemia major, E beta thalassemia, hemoglobin H disease, and alpha thalassemia major. And the answer, as you can see, really is no. The reasons are described below. First, the use of common guidelines overlooks the variable pathophysiology of the different thalassemia syndromes. So patients, as I already mentioned, could have different tolerance to anemia and have different oxygen transport characteristics. And the second is that the degree of ineffective erythropoiesis also differs. And typically, alpha thalassemia patients' syndromes have much lower ineffective erythropoiesis. The second issue is in certain thalassemias, for example, in alpha thalassemia major or Bart's hydrops, there is a significant amount of non-functional hemoglobin, either Bart's or hemoglobin H. This hemoglobin gets measured as part of the total hemoglobin but does not contribute to oxygen transport. This means that patients with alpha thalassemia major cannot be transfused by guidelines developed for beta thalassemia. And the third issue is that transfusion needs, even within the same person with thalassemia, will change with age, and mild phenotypes that look mild during childhood may start to cause severe symptoms in adults. Here are listed some of the sources that we've used for making our recommendations of Thalassemia International Federation guidelines from 2014, the Thalassemia Management Checklists that were developed during 2018, the Standard of Care guidelines that were developed by Oakland Thalassemia Center in 2011, Thalassemia Western Consortium Consensus in 2018-2019, and more recently, the International Collaboration for Transfusion Medicine guidelines. So what are the indications to start chronic transfusions? First of all, if the hemoglobin level is less than 7, if the hemoglobin is less than 7 on 2 occasions, Then if the diagnosis is beta thalassemia major, then transfusions should be started. But if the diagnosis is E beta thalassemia, then along with the lower hemoglobin below 7, we also are seeking symptoms from anemia that may or may not be present. The rationale is that if beta thalassemia major, it is well established that once the hemoglobin levels fall below 7 in young children, there is going to be a massive bone marrow expansion, and there will be severe symptoms from anemia. But the relationship of hemoglobin with symptoms in E beta thalassemia is less precise due to reasons that previously mentioned. The other thing is that we recommend testing for the hemoglobin twice, just to exclude the effect of an acute illness on the anemia. But what if the hemoglobin is greater than 7? Yes, these individuals may also need to be started on transfusions, and the guidelines are over here, and these usually mean that the anemia is having a significant effect on physiology or quality of life. So if the growth is being affected in infants, children, and older children, if there are significant skeletal facial changes, if there's a splenomegaly, so either the spleen is big or the spleen is enlarging rapidly, that is an indication to begin transfusions, or if transfusions are already being given, to maybe intensify transfusions. There's the presence of extramedullary hematopoiesis, if it's symptomatic, then of course, but also if it's a moderate to severe extramedullary hematopoiesis. Cerebrovascular events, stroke, silent infarcts, arterial narrowing and moya, venous thromboembolism, pulmonary hypertension, osteoporotic fractures, and quality of life in adults, decline in capacity to work or perform usual activities, can all be reasons to start transfusions even when the hemoglobin level is greater than 7. What are the recommendations for target pre-transfusion hemoglobin, volume, and rate? In beta thalassemia major, we recommend that the pre-transfusion hemoglobin be maintained at an average of 10 grams per deciliter, with a range of 9.5 to 10.5 grams. In E beta thalassemia, the range is wider for reasons previously mentioned, and the frequency of transfusions we recommend in routine is 3 weeks, but it's also acceptable as 4 weeks in young children and possibly in patients with E beta thalassemia. The rationale is presented below. The mean pre-transfusion hemoglobin of 10 alleviates symptoms of anemia and consistently suppresses ineffective erythropoiesis. This is an adequate target for most individuals, and is certainly a good target to start therapy, which can later on be modified if necessary. But we also recommend individualization of hemoglobin targets for patients with E beta thalassemia, and the reason to transfuse every 3 weeks is to reduce the peak to trough variation in hemoglobin during the transfusion cycle. The volume of transfusion usually is decided in children based on their weight. So the volume is approximately 4 cc's per kilo for each gram in hemoglobin that is desired. So in general, children who are on 3-week transfusion schedule may receive 14 to 16 cc's per kilo of transfusion. In adults, we transfuse by units. So it's either 2, 3, or 4 units per transfusion. In general, 3 units are needed for pre-transfusion hemoglobin is less than 10, and 2 units if the pre-transfusion hemoglobin is 10 or more. But in adults, it's also important to adjust the hemoglobin thresholds based on fatigue or bone pain that may happen prior to the transfusion. Finally, patients who have intact spleen, which we expect almost all the patients now to be, are likely to have higher transfusion needs. But this is even more so if the prior transfusions have been inadequate and if the spleen has become enlarged. Splenectomy is no longer recommended unless under exceptional circumstances. The rate of transfusion is mentioned here, usually about 5 cc's per kilo per hour for children, and adults 200 or 300 cc's an hour, which is based on tolerance. But if there is a concern over cardiac function, then the volume and the rate has to be reduced to tolerance, and Often Lasix may need to be used as well. The type of RBC product should be leukoreduced at pre-storage time, and the storage solution is either an additive solution or it's CPDA. And it's important to note that the hematocrit of the two is quite different, and that needs to be inculcated into the decisions on how much volume to transfuse to younger children. It is not as important for adults, though. The age of the unit should be less than 2 weeks where possible. And that's the general recommendation. It's to select younger units, and washed RBC units may be needed for patients with severe allergic reactions. We recommend no irradiation of RBC units. The rationale for these is presented below. The leukoreduction decreases febrile reactions, HLA aluminization. The fresh units, less than 2 weeks, we believe increase the survival of RBCs post-transfusion. They are not recommended for one-off transfusions in hospitalized patients, but for patients on chronic transfusions, we believe that selecting younger units is beneficial. Wash units are required to remove residual donor plasma proteins that can cause severe allergic or anaphylactic reactions. And finally, irradiation is not recommended because it does not benefit the patient with thalassemia, but it does damage the red cell membrane. And these are the recommendations for antigen matching for RBC units. If the person with thalassemia has no pre-existing alloantibody, there is no alloimmunization, then it is recommended that they are matched to RH, which is the CE, as well as the CAL antigen. Those who have pre-existing antibodies should be matched to RH and CAL, but also to an extended group of antigens listed here. Autoantibodies can also develop in thalassemia, but if it's a transient autoantibody, which can sometimes happen during intercurrent infections, then there's no change in recommendation. But if the autoantibody is persistent, then this is a relatively higher risk situation, and extended phenotypic matching is recommended. And again, if the age at starting transfusions is older, then the risk of alloimmunization is higher, and extended matching should be considered. And finally, if the transfusions are first initiated during pregnancy, that's a very high risk state for alloimmunization to develop, and extended matching is recommended. And the final point is that it's important to communicate with the blood bank. Hospital EMRs should have thalassemia transfusion protocols that can trigger the protocol to have a fresh sample to perform antibody screen, antibody history, phenotypic matching, and the need for wash blood. And there is also needs to be communication between the blood banks. We recommend that now all patients with thalassemia should have their red cell antigens determined by DNA testing. And this is a summary slide that will be uploaded along with the webinar. We now move on to the third section of the last section of today's webinar, and Dr. Wyszynski will present the transfusion recommendation for other types of thalassemia.
Thalassemia is a heterogeneous clinical diagnosis, and one of the most difficult groups is the group called a non-transfusion dependent thalassemia. It's not that simple. In fact, it's made up of a group of heterogeneous complex mutations that vary in severity and that can be off of transfusions often when they're young. However, there is an international movement to reclassify this group so the medical community is not confused to think these are just non-transfusion dependent. These are seriously ill, serious patients who have a lot of risk factors, and in general, as they age, most of them get increasingly exposed to transfusions and eventually transfused. And the second group I'm going to mention is as newborn screening programs are moving into alpha thal testing, the results on and how to manage these patients. There are real benefits to transfuse a non-transfusion dependent thalassemia patient based on their clinical picture. In NTDT patients do not necessarily need indefinite regular transfusions, but there are periods in their life when significant morbidity can be prevented by transfusion. Hemoglobin alone should not be the sole determinant of transfusion needs in these populations. And as Ash indicated, hemoglobin E-thal is an excellent example of these. By and large, non-transfusion dependent patients, one needs to really interview and spend time to understand their well-being, their activity, their growth, their quality of life, the skeletal changes, and other factors that are influenced by hemoglobin. Some of these groups, such as hemoglobin H constant spring, a non-deletional H, often gets recurrent transfusions during a rather non-serious infection, such as a virus that induces hemolysis, or during the period of growth. Transfusion programs are beneficial for NTD patients, but they really require close management and a timeline to stop. In general, 1 gram change in a thalassemia or NTD patients has a major effect on their morbidity. Patients under 7 have much greater morbidity than those over 10. And despite being transfusion independent, transfusion therapy can ameliorate their anemia, their hemolysis, the side effects of ineffective erythropoiesis, and many of the problems that result in poor quality of life. Thus, many of these patients in middle age are chronically transfused. On the left of this slide are general common problems that develop in patients who are not transfused: growth failure, life-threatening hematopoietic tumors, pulmonary hypertension, silent brain infarcts, severe skin ulcers, sometimes uncontrollable bone pain, overall quality of life, hemolytic events, sometimes a very large, rapidly growing spleen, a failure of secondary sex characteristics, and disturbing facial changes. There is a risk to transfusing this population. They're older, and when you transfuse them, they can get iron overloaded, but the ferritin does not accurately reflect the total body iron. And so for reasons we don't have time to explain, the ferritin underestimates the iron burden. So intermittent transfusions in this population requires liver management. In addition, if you start transfusions in an older splenectomized, non-transfused patients, they have an explosion of alloantibodies, which can be prevented by extensive phenotypically matched. So transfusing them as indicated is a worthwhile endeavor, but have a goal in mind about when you're going to reassess stopping the transfusions. Alpha thalassemia major and alpha thalassemia disorders are rapidly on the rise in California and other parts of the world. These high-risk communities, such as Philippines, Southern China, Southeast Asia, Thailand have enormous populations, and historically they were all felt to be non-viable. However, advances in prenatal treatment and in improved postnatal care makes us reflect and potentially change this paradigm, and at least to offer other options to families besides termination. So in general, preconceptual screening is necessary, prenatal testing, monitoring of pregnancies with ultrasound, and on the right, you could see a simple transcranial Doppler of the fetus can very safely separate out which fetuses are severely anemic without any invasive testing. In fact, the accuracy of the middle cerebral artery is over 90%. Now, if you have an at-risk case, then you can make a decision to transfuse them before they develop irreversible damage. And during the fetal transfusion, you want to monitor and measure BART, hemoglobin A, and give fetal blood products that are CMV negative under 7 days, radiated with a very high hemoglobin mass of 75% and optimally cross-matched with the mother first. Now, we have been doing that, and these babies appear to, with serial transfusions, to survive and have a relatively normal neonatal period. So then they're moved into the problem of post-transfusion. And increasing evidence suggests their transfusion regimen needs to be somewhat different than beta thal major. And in the recent studies by Amid and others in a Toronto group, as well as our own, you have to transfuse them to a higher pre-transfusion level. This compares conventional transfusion for beta thalassemia goals to the aggressive alpha thalassemia protocol for alpha thal major. Basically 10 transfusion as a pre versus 12. And you could see with that little extra transfusion, you could lower the hemoglobin H from 42 to 19%. This is critical because hemoglobin H doesn't carry oxygen, and therefore it's a non-functional hemoglobin. And when you separate it from the total hemoglobin value, which is 10, you will see that they only have a functional hemoglobin of 5.8. This can be prevented by a higher hemoglobin, and it corresponds to a dramatic fall in the EPO drive from 363 to 48, a similar fall in soluble transfusion receptors, reticulocyte counts, and serum bilirubin. So in summary, alpha thalassemia major, and these are two of the babies I'm following now, is a changing disease that has growing questions of ethics and options. Early serial fetal transfusions and an aggressive postnatal transfusion program offers the potential for neurocognitively intact child with a relatively good quality of life. At-risk couples should be identified early and offered, in addition to the standard termination, the option of early fetal transfusion. There are newer therapies coming out, and we are actively involved now in an FDA-approved in utero maternal haplotransplantation that is remarkable in that it turns out the fetus maintains fetal tolerance to the mother, enabling a transplant from the mother to occur without any cytoreductive preparation. And this is an ongoing trial. So that concludes our overview, and we welcome questions.
So we will now shift to the question and answer section of the webinar. Again, to submit a written question, please use the questions area of your toolbar. So one question is what are the benefits of transfusing patients with blood that's less than 2 weeks old, and is this the guideline of standard of care practice?
This is a significant issue, how old the blood should be, and each case should be monitored in a discussion between the transfusion program and the doctor. Fresh blood under 2 weeks old has a longer half-life in patients. It appears to lower the infection rate, and in addition, it decreases the release of procoagulants and particles, and therefore it seems to be beneficial in lowering thrombosis and potential of infectious rate. So while this is controversial, the clinical benefits do, in our opinion, recommend its use.
So there's a question about heavily immunized patients, and if at some point, due to the presence of multiple antibodies, it can become difficult to obtain blood reliably from the local blood bank. And I have to say that this is one of the very serious and probably the most serious threats to long-term transfusion therapy in thalassemia, which is the reason why phenotypic matching of blood in persons who do not even currently have alloantibodies is being recommended. But in cases where, in those rare cases that will develop multiple alloantibodies, the blood may need to be procured through a national network, And in these cases, the rare units can often be frozen and then shipped around the country to the patient who might need it. But we are hoping that these instances will become less and less common in the future. So the next question is it better to get units that have long expiry date versus units with short expiry date at the time of transfusion? Does it make a difference in how much longer the transfused RBCs will be viable for after transfused?
There are two factors that are important that are kind of need to be taken into the equation based on the individual patient. Number one is you want to be able to get matched units. In patients with uncommon antigens that need to be matched, you may need to have units that have a very long shelf life to store them. In general, that hasn't been our issue. The other issue that I think is very important, depending on the cases, is what is the hemoglobin of the transfused unit. And this is reflected by the preservative that are used. I think it's very important for the physician to understand that the blood bank units that you give can vary dramatically by the preservative or non-preservative, from a hematocrit of 50 in one unit or 45 to a hematocrit of 80 in the other. So knowing this difference based on the preservative is critical in determining the type of blood you want, because you may require units that have high hemoglobin in certain patients, or those with multiple rare antibodies or antigens that you need a longer shelf life for. But it is important to understand what is the hemoglobin of the units you're getting. Is that critical to what you need? Can the patient number two is, do you need to store units over time in determining the factors about which ones to use?
So there are multiple questions about the age of the units at the time of transfusion, and that if the blood unit is more than 2 weeks old, then should that be used or not? We don't. So I think one thing that needs to be clarified is that choosing a younger aged unit is the goal, but a unit of blood does not go bad up to 2 weeks. So even the blood that is older at the time of transfusion is perfectly good to use. It is that over the long term, the policy should be to choose as young a unit as possible. And the recommendation for blood banks is to try and issue units that are younger rather than issuing units that are close to the end of the expiration date, which may happen for other patients that are hospitalized and need blood for intermittent transfusion.
Yeah, in other words, we prefer younger units if it meets the patient's needs. However, we would not, if that's the only unit there and it's best matched, we clearly will use it. We would prefer the blood bank give old units to short-term transfusion patients in the hospital. In general, you could get them, but if it's an older unit within a safety duration and that's what you have, we would use it. It's just our recommendations are to get the younger blood.
If one has to choose between a slightly older unit versus a phenotypically matched unit, we would always prefer a better matched unit. Intermediate, beta thalassemia intermediate.
Oh, I can answer that.
Yeah.
One question is, what about regular transfusions for beta thal intermediate? Well, this is frankly where the physician really should rise to the occasion. And what I am opposed to is plugging patients into a static formula and then telling the nurse practitioner this is what they get. Every patient, and in particular the thalassemia complex thal intermediate-like groups, should be closely reevaluated every 6 months in terms of their transfusion regimen, because many of their transfusions may be modified. It doesn't mean they won't benefit from chronic transfusions, but one of my interesting observations is within this subgroup, there may be periods when they just need chronic transfusions. Overall, I would say that as patients age, they do much better on chronic transfusions. My own personal approach is to a family in that gray zone is say, hey, let's try 6 months of transfusions and keeping your hemoglobin up and see how you feel. And if after 6 months they say their quality of life is dramatically better and they have a decrease in terms of fatigue, morbidity, better school performance, or shrinkage of things, then we continue them. If after 6 months they say, well, I don't really feel that much better, and there isn't an underlying problem like a spinal mass, then I stop them. I think engaging the family into this treatment program is essential.
There is a question about the use of split units or partial units for children. And since children are growing at a continuous rate, the amount of blood that is needed to maintain the optimal hemoglobin level is going to continue to slowly increase, so that at some point in time, a full unit may not be enough, and it is likely that you would need to use part of a second unit. And is this considered blood wastage? Well, we don't think so. I think in larger centers where patients may share similar red cell phenotypes, then the units can often be shared. And in other cases, the blood bank can issue smaller or part of the unit, and the rest of the unit can be used for other needs within the hospital system. So there are multiple ways to get around the problem of how to use the remaining part of a unit. But we feel that by not utilizing a partial second unit, many children who are especially within the age group of 6 to 10 years or 5 to 10 years may be getting under-transfused, and that could have an effect on their growth potential and other activities. So there's a question on the use of pre-medications such as antihistamines, steroids, or diuretics.
This is an important question because there are not good standards. But by and large, the studies that have been done, and there have been some larger studies completed, basically demonstrated that in patients who don't have reactions in history, the preventative utilization of antihistamines is not beneficial, and that antihistamine pre-reaction should be not given, but waiting for the development and then the prophylactic use of antihistamines. Similarly, the question of, I think was mentioned, diuretics, was that right? I think fluid overload is a serious problem as the patients age. And I think some of the patients actually feel worse after the transfusion, and I often think that's due to one factor, is overload. There are two ways to address that, three ways. You could spread out the transfusions and transfuse them more frequently. Two, you could use higher hemoglobin containing units. As I discussed, the variation in hemoglobin can be 75 down to 45. And three, you can transfuse them over a longer period of time or use minimal Lasix. In the aging senior citizen patients I have, and I have a growing number of thalassemia patients in their 60s, I often use a small dose of Lasix in patients who have early cardiomyopathies.
There's a question on the use of transfusions in non-transfusion dependent patients during pregnancy. What are the clinical findings that trigger a transfusion? So We usually follow the, the policy that if the hemoglobin level drops below 8, we would offer blood transfusions. And in these cases, especially if there's only been intermittent transfusions or no transfusions in the past, the risk of alloimmunization is extraordinarily high and could, in fact, be a problem for transplacental passage of the alloantibodies that the mother may form. Therefore, we would perform an extensive phenotypic matching and provide CMV negative blood. But our goals in management are not as similar to that in a beta thalassemia major. And we often accept a hemoglobin pre-transfusion level of 9, and preferably trying to keep it below 10 or no more than 10.5 in the pre-transfusion period. I think we are at 12:05, and we would just take this one last question, which is said that the question is about irradiation of blood products. It is said that irradiation will reduce the risk of GVHD.
This is an important question because patients are getting units that are radiated when it's not indicated. And I think this stems from the fact that most blood banks with large oncology programs are radiating all units. They cost money, it's charged to the patient, and there are risks to radiation. In particular, the risk to radiation is it doesn't sterilize the unit. It prevents graft versus host disease, and in large part, this population has a very active and robust immune system, a cellular immune system. So we don't use radiation therapy. There's no evidence it's a benefit in a thalassemia patient. The one period where radiation therapy may be of use is clearly in patients who have immunodeficiency syndromes, or if a patient is in the window to be transplanted. That doesn't mean patients who may go on to transplant in the future. It's really in a very small window of the pre-transplant period. Thank you. I would love to continue this conversation, but time is short and I probably have spoken too long. I would like to thank each of you for joining us. We thank our colleagues at the Cooley's Anemia Foundation for hosting today's webinar. Very shortly, you will receive an email asking for your feedback, so please respond with your comments. If you have any additional questions about today's presentation, please contact Cynthia Sayers at csayers@cdc.gov, and we thank you very much for joining us.
Thank you.